and I am a professor and endowed chair at the University of Kentucky in Lexington in the United States. My field of interest is self-care of all sorts of cardiovascular conditions, especially heart failure, acute coronary syndrome, and lately I have been working on self-care related to prevention of cardiovascular disease. I'm going to be the moderator of this meeting today. It's my distinct pleasure to be joined by Dr. Kyoung Suk Lee. Dr. Lee is an assistant professor at the College of Nursing in Chungnam National University. She's in South Korea, and I'm in the United States. This is quite fun. Kyoung Suk is the lead author of the paper that we'll be discussing today. It's called Self-Care of Rural Residents with Heart Failure. What are we missing? This was published in the April issue of the European Journal of Cardiovascular Nursing. So to start off the session, I'll just have Kyoung Suk give us a short introduction of herself and then of the journal article, and then we'll have some questions.
Hello, everyone. I'm Kyoung Suk Lee, the first author of this paper. It's my great pleasure to discuss this paper with you today, and my great honor to have Dr. Moser as a moderator of today's session. Let me first briefly introduce this paper. As you can see from the title, we would like to explore self-care among rural dwellers with heart failure, as self-care is a complex process requiring patients to understand heart failure and its signs and symptoms and change behaviors and lifestyle. Poor self-care is common in this population. However, inadequate self-care may not be solely responsible for patients' lack of understanding of self-care. For example, if there is not enough grocery stores around the patient's home where fresh fruits and vegetables are available, it would be challenging for patients to follow recommended diet regimen even if they want to. Similarly, adherence to self-care behavior and its influential factors can be different depending on where patients live. Therefore, we would like to explore what factors are related to self-care in heart failure patients living in rural areas. We did the secondary data analysis of the baseline data from the large randomized controlled trial targeted to the heart failure patients living in rural areas in the US. To comprehensively explore the variables related to self-care, variables were selected based on the multidimensional life course model of heart failure patient self-care. Variables that we included to predict self-care were health literacy, depressive symptoms, anxiety, perceived control, social support, socioeconomic status, education level, current symptom status, cognitive status, functional status, and comorbidities. Those 12 variables explained a total of 7% of variance of self-care, which was much lower than we expected. This limited explanatory power of the variables in relation to self-care in our model can be related to three factors. One is that we did not include all variables suggested in the life course model, such as prior experience of a healthcare system. Second, some measurements used to assess factors in the life course model may not be ideal because of secondary data analysis. Last, most factors that included in our regression model was intrapersonal factors. Because health behaviors are affected by both intra and interpersonal factors, it is important to assess interpersonal factors such as cultural values and access to health care to fully understand self-care. Because rural dwellers have unique social and cultural attitudes and challenges to access to or availability of health facility and services, it is very important to consider interpersonal factors along with intrapersonal factors when investigating self-care in this setting. Therefore, what we are missing in this population so far is including interpersonal factors. Therefore, we should understand and incorporate inter and interpersonal factors simultaneously when assessing self-care and designing interventions to improve self-care.
Thanks, Kyoung Suk. That's a great summary of a really interesting paper. So I think some of the strengths to highlight of the paper are that it's a nice big sample size. So you had the capability of finding associations that were present, even with your 12 variables. People often worry about that, of course, too many variables, but you had over 500 subjects, so that was great. And we'll talk about this a little bit later, but there were some very distinct predictors that we can do something about. And also a strength is that you tested a model, an existing model that was proposed in the literature, but had never been fully tested. So I know that you tested that model in this paper, and others have tested it, and it leads to the suggestion that parts of the model could be modified. So I think this is a wonderful paper on many levels. Let me start with the first question, and this is from Anomi Osokpo, a student at the University of Pennsylvania. And she asks that culture is a complex and multidimensional variable and not just a nominal variable such as race and ethnicity. So a lot of times people think they measure culture just with race but of course it's much more complex than that. And then she notes that within cultural subgroups, there are even cultural differences and nuances. And she wonders, how do you think that future studies can account for the impact of culture?
Okay, so it is a really good question. First, let's start over the reviewing the definition of the culture. Although the clear definition of culture has not been emerged, current definition of culture expand beyond race and ethnicity and share commonalities of sharing or integrating learned values, belief, and norms in patterns of behavior. So because the culture is very important and it is influential to patient health behaviors, we need to consider how we can incorporate the patient's culture. At the same time, it is very important to consider how patients perceive whether they received culturally competent care or not. So one way we can measure whether patients receive the culturally competent care is based on the two ways. One is that we can ask providers whether they provide culturally competent care or not, or we can ask patients whether they received those cares or not. So I reviewed a couple of measurements that can measure cultural competencies. The first, there are several measures to assess cultural competencies in healthcare providers in their perspective. Recently, an integrative review on the measure of cultural competency was published by Loftin and colleagues. Of 11 measures included in the review, 7 were designed to assess cultural competency in providers, such as cultural self-efficacy scale, inventory for assessing the process of cultural competency, and cultural competency assessment. However, authors mentioned that psychometric soundness of these measures were not widely investigated, and domains of cultural competency as defined for these measures vary. Therefore, more research is needed to develop or revise instruments to assess cultural competency among healthcare providers. So we can also measure patient perception to their healthcare providers' cultural competency using a couple of measures. One example is physician bias and interpersonal cultural competency measure developed by Johnson and colleagues. Examples of items in this measure are I feel that my doctor understands my background and value. And do you think you were ever a time when you would have gotten better medical care if you had belonged to a different race or ethnic group? Although culture, we already mentioned that culture is beyond the race and ethnic group. Some of the measures or some of the items in this measure addressing discrimination due to race and ethnicity rather than cultural background. So there is more room to improve in this measure. And the other thing we can think about is that the term patient-centered care. These days, cultural patient-centered care has received a lot of attention because it increased the patient's health outcomes. So if we look at the definition of patient-centered care, is that it is defined as providing care that is consistent with the values, needs, and desires of patients, and is achieved when clinicians involve patients in healthcare discussion and decision. This approach is an effort for providers to understand the patient's experience with their illness process and patients as a whole. Therefore, strategies to provide patient-centered care can be beneficial to provide culturally competent care to healthcare providers living in rural settings.
Great, thank you so much. Our second question is actually related to that first one. So you can see that there's a lot of interest in cultural beliefs and relationships with healthcare providers. And Sophia Kitsti asks, do you believe that variables such as cultural beliefs and relationships with healthcare providers could change your research results? And she also says, could you give us a measurement to assess those variables? And I know you just talked about a lot of measures, but maybe you could reiterate.
Mm-hmm.
Thanks.
Okay, so I truly believe that if we include variables measuring cultural belief or relationship with the healthcare providers, if we include those variables, our power to explain the self-care in our population will greatly improve. So, because unfortunately, our study was a secondary analysis, we were not able to include those variables. When I look at the published study, Cheryl and colleagues reported their success and challenges in developing and implementing the accessible and culturally competent health project for underserved population in a county in the U.S. They included multiple strategies to provide accessible and culturally competent care to rural Latinos, such as being held a focus group comprised of patients in the community, training local lay persons as an informal advice giver, having bilingual interpreters who are trained to do accurate medical interpretations in a culturally sensitive way, and building an interagency collaboration. And patients in the community were satisfied with the care they received, and especially they appreciate the regular presence of trained interpreters and Spanish-speaking staff. Similarly, Dr. Moser, our today's moderator, also did the community-based intervention to improve heart health. She also used lay people in the community as a key person for the recruitment and intervention, and design intervention strategies that are appropriate to the culture of the community. Her research was very successful to improve heart health in this rural community. So again, to improve self-care, we need to consider that their cultural values, especially in rural setting. So if we include those variables, our model will explain more in self-care. As far as measurement, I mentioned a comparable instrument that can measure cultural competencies from provider's perspective and patient perspective. The most, although I listed several instruments, The most commonly used instrument to measure providers' culture competency is inventory for assessing the process of cultural competency. Although the developer also has a website to introduce this instrument and provide reliability and validity studies, however, there are not many studies to show its validity. So as far as the questionnaire that can measure patient perception to their provider's cultural competency is physician bias and interpersonal cultural competency measure. However, I do not see that its validity and reliability study, so I think we need to develop or revise or retest this measure, whether it is a valid or reliable measure to measure patient perception to their provider's cultural competency.
Great points. It does become really difficult to get somebody to write down in a survey and respond to a questionnaire these really complex issues. So those are some really good points, but also point out really the importance of us beginning to delve into developing those sorts of questionnaires, even though it's going to be hard. It'll really be hard. Let me go on to the next question. This is from Katerina Filipau from Cyprus University of Technology. And she wants to know if you'll summarize the variables significantly related to self-care in the rural patients with heart failure. So out of those 12, which were the important ones. And she also asks what other characteristics of rural areas might be important components in explaining self-care of heart failure patients in rural areas. So 2 questions.
The answer to the first question is that as far as individual variables that predict self-care in rural setting was depressive symptom and current symptom status, and then income. Higher level of depressive symptom, higher levels of current symptom status, and lower income independently predicted poor self-care. Answer to the second question, as I already mentioned before, it is very important, including interpersonal factor, interpersonal variables, so that we can fully understand self-care in rural settings, such as patients' cultural values and belief and their relationship, their environment as well.
Great. You know, one of the things I really noticed in performing the study, the main study from which this analysis is developed, is that there were a lot of environmental issues that really affect rural patients. For example, a lot of rural patients live down, a funny story is that one of our patients said, I live on River Road. And so we visited patients to do data collection, and we had a really hard time finding this area because it wasn't on the GPS. And finally we called her and she said, River Road, you got to go on the road that's under the river. So it was actually driving down this stream to get to her house. That's why it was called River Road. So there's a lot of issues with accessibility. So not just getting there, but also them getting out to even get to healthcare, to get to a grocery store. And then, of course, many of these people live in food deserts where there isn't good access, easy access, or close access to good foods. And even then, we actually did a survey of all of the stores that were available, and we found that there really, actually, for most people in these very rural areas, there's no access to fresh fruits and vegetables. So a lot of the things that we suggest to people, we sort of get mad at them if they don't follow our recommendations, but in fact they can't. So we really have to think about the environment in which rural people live in and begin to, tailor our advice to what is possible and help people figure out what's possible or not in their areas. Let's move on to the next question. This is from Iona Lakatamatu. And she's a cardiology nurse at the American Medical Center, American Heart Institute, Niswosia. She says, it's of great importance that in the results of your study, 72 or 77% of participants were living with someone else, a caregiver, that could serve as a caregiver. As you mentioned, in rural culture, there's a strong sense of family and community that is usually the primary resource for problem solving. How important do you believe is the inclusion of family members in the education of people with heart failure in rural communities? And how can this be applied in an educational program for both of them?
So that's a good observation. That is a very good observation. So family plays a important role in patient self-care. There are many studies showing caregivers' substantial contribution to patient self-care. As a strong family connection is one of the important social structures in rural residents with heart failure, including family members to heart failure education, it is important to improve patient self-care adherence. All education programs for patients and family members were not effective to improve patient self-care. What is missing in effective intervention may be not considering the relationship quality between patients and their caregiver. According to the study by Dunbar and colleagues, 2 patient-family programs involving either self-care education, called Family Patient Education Group, or education combined with a session to improve family partnership and autonomy support communication, called Family Partnership Group, were effective to improve low-sodium diet but not medication adherence. The result of the study by Dunbar and colleagues were reanalyzed by considering the baseline family functioning. This follow-up study showed that patients' motivation to adherence to diet and medication at baseline was significantly different between patients with good and poor family functioning at baseline. And after adjusting for baseline family functioning, significant improvement in motivation to improve diet and medication in a family partnership group after the intervention were observed, while no difference was found in usual care and a family patient education group. Therefore, it is important to assess the level of family functioning and include strategies to enhance family functioning when designing education programs for patients and their caregivers.
Great, good answer. And it's nice that she asked that question, because we, really, of course, are beginning to understand the very important role of caregivers, and especially for heart failure patients, given the issues that are very common in them, like cognitive dysfunction, depression, as you saw and demonstrated, and others have, that it really has a big impact on self-care. Let me ask you, so now I can ask you one final question. So this was a secondary data analysis, and it has limitations, but it also opens up, secondary data analysis, I think, open up many opportunities for others to look at your data and really expand the reach of the data, use the data so that we really give respect to all the patients who provided us with data to answer additional questions. And I wondered if you could just talk a little bit about how you access this data, and how ultimately it can be pretty easy to do secondary data analysis by even though you and I know each other, and it was probably easy for you to get the data from me, but I would consider any request for data. So I'm hoping you could talk a little bit about doing secondary data analysis to encourage other people to consider such things.
So I'm very fortunate to be able to use a large data set that already collected by Dr. Moser and her colleagues. So I am very lucky to have you and other good researchers. Because of that, I was able to publish multiple papers from those data. So if you because we're using existing data, so we can ask lots of questions from the data that is already collected in a rigorous way. So to to be able to make good data, secondary data analysis is that first you have to be very familiar with the data set so that you know that what kind of variables would be suitable to answer your questions. So to do that, you have to communicate with the researchers who own the data set, so that with a good relationship and good discussion, you can better make, when you select the variables, you can do better job, and then you can do the better analysis, and then you can make the discussion more better. So for my tip to do the secondary analysis is that first familiar with the data set, and then discuss a lot with the researchers who have the data set.
Great, that's great. That's a great idea, so I'd really like to point out that most researchers actually love inquiries about their data. So don't be afraid, anybody, to approach researchers who you think have, big data sets, who might be interested in working with you to publish data. All right, we're going to wrap this session. That was our last question. I'd really like to thank you, Kyoung Suk, for presenting your study and answering these questions. It was really a great study and a delight to be able to talk to you. I'd also like viewers to go and take a look at the European Journal of Cardiovascular Nursing homepage. You can find this on the Sage Journals platform, and you can get access to the entire journal and take a look at what is being published there. We can answer your questions about anything we've said in the session or about the paper if you email EJCNclub@sagepub, SAGEPUB.com. And I'd like to thank everybody for watching this session. Thank you very much. Goodbye.
Thanks.